Usually I draw it as we're going along, but I can't do that now. Okay, so any questions before we begin? Okay, so I am going to start with a question for you. So urinary, excuse me, urinary tract infections. What are the, give me 3 signs, 3 symptoms of urinary tract infection. Signs, symptoms, urinary tract infections. 3.
Burning.
So in the chat box, please, so that I can, so burning was 1. So please clarify what is meant by lack of relief. I'm not quite sure I understand. So are you speaking to, so urinary retention? Is that what you mean by lack of relief? I just want to make sure I understand. Okay, I am seeing a lot of, okay, I'm going to start at the top. I'm going to scroll through very quick. Okay, so I see a lot of signs and symptoms that are not actually the cardinal signs of a urinary tract infection. So typically you can drill a urinary tract infection down to 3 things. Fever is not one of them. Go through and tell you what's not before I tell you what is. Pain and burning are basically the same, okay? Fever is not one, blood in the urine is not one. Suprapubic pressure is not one. Delirium is a very late stage. If you see central CNS changes from any sort of infection, that's a late stage. So not really considered a cardinal sign. You might not see a change in your white count. Actually, you typically don't have urinary retention. Difficulty, usually the pain is not due to any sort of obstruction, but the pain is due to more to an irritation. Not bleeding, not bleeding. Malodorous is not one of the cardinal signs. Okay, so microscopic hematuria. So those are not, so that you might get on exam, but your cardinal signs are burning or pain, frequency, and urgency. Those are the 3, okay? Urgency. So I'm not sure if that, I think that's what you meant, sung by, I can't find you. Sorry, you're in here somewhere, but I think that's what you meant. So pain, burning, I'm sorry, pain or burning, frequency, urgency. Those are your 3 cardinal signs. All right. Now, voiding should never be painful. There are times when physiologically during pregnancy, when frequency and urgency are appropriate, but pain or burning is never appropriate. Okay. All right. So on to our chart. During the first trimester, where is the embryo that then becomes a fetus? First trimester, where is it? Which body cavity is it in? Which body cavity is it in? I shouldn't hear silence.
Pelvic.
Or I should see, I want a body cavity though. So it is pelvic cavity initially, right? First trimester, pelvic cavity. Second trimester, where is it? It is now a fetus, and where is it? Second trimester.
Isn't that when it transitions from pelvic to abdominal?
So I want you to say that as a statement, Fred, not as it's not a question. You guys know what you know, so I want you to say it like you mean it. So yes, it is in the abdominal cavity, right? It's transitioning into, from the pelvis into the abdominal cavity for most of the second trimester. It's in the abdominal cavity, and then where's it going? Think back to the pelvic cavity. And when does it shift back to the pelvic cavity?
After
How many?
32.
40 weeks.
30,
40 weeks.
36.
36 weeks. Remember what we spoke about the xiphoid process. We looked at the fundal height chart. So 36 weeks, after 36 weeks, lightening occurs and it goes back down into the pelvic cavity. All right. So thinking about that, first trimester, I'm going to tell you some things about the first trimester, and then you're going to tell me about the second and third. So first trimester, it is not unusual to have an increase in urinary frequency and in urinary urgency because of the increase in vascularity. So remember, you have the sudden increase in vascularity in the area, and you have the impact of hormones. So she may have to go more often, she may have to void more often, and she may have this sense of not being able to hold it. That's urgency. Like, I have to go and I have to go right this second, right? So frequency and urgency are not uncommon, somewhat to be expected during the first trimester due to the increased vascularity, hormones, so on. Now, second trimester, do we expect an increase in, I can't even see my chart. Do we expect an increase in frequency in the second trimester? So I'm down here. That's it, simple yes or no?
No.
Do we?
Yes.
Yes.
Why would we have an increase in frequency?
The uterus expands.
Weight on the bladder.
It's relieving the pressure because it moved up. So wouldn't that mean less?
Right, so I want you to think about this anatomically. Where is the fetus? The fetus is now in the abdominal cavity. So the pressure on the bladder has been somewhat alleviated, right? There's less pressure on the bladder. So the frequency should be decreased. You shouldn't have frequency. And you shouldn't have urgency in the second trimester. So is everyone with me on that?
Yes.
Again, I shouldn't hear silence. Silence makes me nervous, especially when I can't see all of your faces. Okay. All right. Now, third trimester. Think about the third trimester. Where did you tell me that this fetus is? Where did we start out?
It's going to be both because it's moved higher and then it's also bigger and drops. So when it drops.
So is there, so thinking about that, what Fred just said, is there an increase in frequency?
Yes.
Yes.
Late stage third
Yes,
trimester.
okay.
Yeah.
And would there be an increase in urgency?
Yes.
So mainly due to what? To the weight of this growing fetus on the bladder, pressure on the bladder, right? Okay. So I want you to keep that in mind when you're thinking about a patient that comes in and where they are in their prenatal visit. So if she comes in and she's in her second trimester and she's telling you that she has frequency and urgency, are you comfortable with that?
No.
Are you comfortable with a patient in the second trimester telling you she has frequency and urgency?
No.
No.
Should not be comfortable with that. That should be a red flag to you that something is going on. Right? Because you should not have that in the second trimester. Third trimester, yes, because you have this fetus pressing on the bladder. Second trimester, no. Third trimester, yes. Okay, now, so I want you to keep that in mind as we go on and you're thinking about what the signs and symptoms are of urinary tract infection. Remember that, again, remember your anatomy. Our concern is always to make sure that there are no infections, right? Infection, a urinary tract infection can, when you have a urinary tract infection, think about the anatomy, you're increasing the possibility of an infection that can be ascending and that can compromise the fetus. Okay, so how are we going to do this now? All right. Think about the bladder now. What is the impact of estrogen on the bladder? You said it relaxes the smooth muscle. How does that impact the bladder capacity? Does it increase or decrease?
Increase? Increase.
I want to hear an increase with you got to say it like you mean it, right? Okay, so you have an increase in bladder capacity because the smooth muscle has relaxed. But if she's in the third trimester, theoretically that bladder can hold more urine, but now you have the fetus pressing down on it, that decreases the capacity. So you have to think about it in context of when during the pregnancy this is occurring, okay?
Professor, can you go back for a quick second? So for the bladder capacity, the third trimester is the increase and the second
No.
trimester is the...
That's not what I said. I said, think about the impact of progesterone. You guys told me that progesterone relaxes the smooth muscle. Progesterone relaxes the smooth muscle. That means the bladder capacity increases, doesn't it? Yes. So if the bladder capacity increases, you have to think about it in terms of when during the pregnancy this is. So even if the bladder capacity increases, but she has a fetus pressing down on it, she is going to have increased frequency. She's going to have to go to the bathroom more because even though the bladder can theoretically hold more, the fetus is pressing down on it. So you have to think about it in terms of when during the pregnancy she is, all right?
Is it common to have accidental urination due to like the baby kicking or anything like that, or movement?
No, not due to fetal activity. Okay. So, wait, let me just, okay. Well, so the question is if it only impacts frequency. You have to think about it in terms of frequency and urgency, but think about where is the fetus? Is there pressure on this bladder or isn't there? Okay, so you have to put it in context of the timing during the pregnancy. Now, that's the bladder. So I'm actually going to talk well, all right, let me talk about the kidneys. I guess I will talk about the kidneys. So bladder here, the kidneys are up here, right? Okay. So we already said that the perfusion through the kidneys will increase markedly because she has so much more waste to release, not just hers, but from the fetus. Now, the ureters, these are the ureters. What is the impact of progesterone on the ureters? So the ureters are supposed to transport urine from the kidneys to the bladder. If the tone of the ureters is relaxed, what happens to that? What can happen with that urine?
It's gonna pool,
Pool where?
like POOL
Yeah.
in the
ureters.
yeah, it's not gonna be able to, it's not gonna be pushing it through.
Okay, so what can happen with the urine? What might happen?
Back up
It might back up where?
into the kidneys.
Back
Into
into
the
the
kidney. Now, does that sound like a good thing? You're all saying it like this is not good.
No.
So you already know it's not a good thing. I don't even have to tell you that's not a good thing, right? So you can have urine refluxing to the kidney, and this is just a normal part of it's the impact of the hormones, right? Now, I also want you to think about, I don't have a picture of this, but you also have to imagine that the fetus is right there. So you have the fetus pressing on the ureters as well as the impact of the progesterone. So again, the importance of hydration and making sure that she is aware of how often she is voiding. Like she's got to keep this system flushed. She's got to keep the system flushed because you do not want urine backing up, refluxing into the kidney. Okay, so that can cause renal all sorts of, problems with the kidney, dilation, and so on. Let me think of what else. Okay, so kidneys, ureter, bladder. Pregnant women are more prone to bacteremia, so bacteria in the urine. She may have an asymptomatic or she's not sure. She may, okay, so if you have a pregnant woman who has some frequency and urgency, she may think that's a normal part of the pregnancy, but meanwhile, she has a urinary tract infection. So again, think about your anatomy. An infection that starts here in the bladder and is not treated is going to ascend, is going to become a kidney infection, and she's going to end up being hospitalized. All right, so your patient teaching is crucial so that she understands when she should have frequency and urgency and when she should not, and when she needs to come in. Remember what I mentioned before about the increase in vaginal discharge and the glycogen in the vaginal discharge. So again, you have a moist, warm, dark area, add in a little nutrients, and microbes are just happy as ever to grow and to grow and to grow. So you can end up with all sorts of infections merely because of all the physiologic changes that happen with pregnancy. Okay? So teaching is very, very important here. All right. I mentioned already the increase in renal blood flow. There is also an increase in your GFR, glomerular filtration rate. So your GFR is going to increase as well. So that increase in renal blood flow, increase in GFR results in, you may see a trace of glucose, a trace of protein in the urine. It's not uncommon due to the increased GFR. So we check, remember, I showed you last week, and it was on the podcast, that how we dip the urine every visit, checking for glucose, checking for protein every visit. All right, so questions about the urinary tract. All right.
All right,
Hold on, I do. You didn't actually, unless I missed it, talk about the vesicuretic reflux.
Where is that? I'm sorry.
Right there on the bottom, to the bladder.
Oh, this is mainly about the urine refluxing back up because the bladder is not being emptied. But that you don't really have to know. I'm not going to focus on that.
That's all I needed to hear.
I'm not going to really focus. I pretty much covered the main thing, what I want you to really think about.
I'm
all right?
sorry, Professor. So a little glucose is fine, but no proteins, right?
Trace.
No trace protein.
Trace, you may see a trace of glucose. You may see a trace of protein also because of the increase in GFR. Okay. And we'll talk more about when you're concerned when we get to complications, but traces are not unusual because of the increased GFR. Okay. I'm coming back. Don't worry. I'm just, oh, okay. I just had to remind myself of something. Calcium. So, ideally, we've done our nutrition teaching. You're staying on top of nutrition. You know how important the calcium is. So, hopefully we are addressing the nutritional needs and there's adequate calcium in the diet. Now, typically fetal demands do not, the fetal demand for calcium usually does not result in a depletion of the calcium stores if she has adequate calcium intake. So it'd have to be a very severe calcium deficit for the fetus to start to draw calcium from the maternal stores. But as usual, as I said, we always want to make sure that we are teaching so that the nutrition is meeting all of these needs that we're talking about as we go along, okay? All right, postural changes. So I spoke about relaxin already and how it relaxes the ligaments. We talked about it relaxing the ligaments of the rib cage. It also relaxes the ligaments of the pelvic girdle in preparation for childbirth. So if it's relaxing the pelvic girdle, which is your base, right? This is what makes your stability. If you have instability in your pelvis, what is your concern here? Actual physical safety, okay? Actual physical safety. So I want you to think about that as we talk about the postural changes. Now, where is your center of gravity? I want you to think about, because I'm not going to be able to see. Usually I have you point it out for me, but where is your center of gravity? Is it above the waist or below the waist?
Around just above the umbilicus.
Right. That is your center of gravity. Now, as pregnancy progresses, as we go from, say, 12 weeks to 40 weeks, think about where the center of gravity is. It's right about here, right? So as the center of, if this is the center of gravity, as her uterus becomes more gravid, larger, she has to brace backwards to form a somewhat of a lordosis as the center of gravity pushes forward for stability. So as pregnancy progresses, you will see more of this lordosis forming. Without that, she's going to topple over, right? Because her center of gravity is here. So she will topple over. So you're going to see this angle become more progressive as the pregnancy goes on. Okay?
I have a question.
Yes.
I obviously get the forward movement of the center of gravity, but also due to the weight change, would it also start to lower it a little bit as well? So it's a forward and lowering of that? Or no?
I'm not sure if I understood you about the weight.
Okay,
change.
so the baby is growing, so the
The
weight is
fetus.
changing,
Okay. I
right.
didn't know if you meant her weight or
Oh,
the
sorry,
fetus.
sorry.
Yeah,
specifically.
no, I just wanted to be clear. So
Yeah.
yes, that's what I mean by the center of gravity. She'll topple over if there isn't the lordosis for balance.
And I don't know if you're going there, you probably are, but with the relaxation of the pelvic girdle, is there a concern for like popping out of hips or something like that?
Yeah, we're gonna talk about that. Yeah. So just a reminder that the center of gravity shifts. Well, actually, let me show you. Oh, I went the wrong way. So you can see an exaggerate. So lordosis is this exaggeration of the lumbar curvature, but again, it is to balance for the shift in the center of gravity. So Simona, you had mentioned kyphosis. There can be some thoracic kyphosis. We don't see this on every patient, but you definitely will see the lumbar lordosis.
Yes, I know.
Okay.
Can
So-
we have those slides, Professor? The previous one, we don't have it.
So as I said, not you won't get every single slide.
Oh, okay. What we need. Okay.
Okay, so we're clear on the center of gravity. The center of gravity shifts forward. The increase in lordosis. Now, think about with all of these changes happening and relaxing the stability of the pelvic girdle. What is probably one of your favorite nursing diagnoses from fundamentals you should be thinking about, right? Risk for falls, absolutely, risk for falls. And you can see why we do not recommend pregnant women, even though you will see them wearing their 4-inch stiletto heels and their 5-inch red bottom beautiful pumps. But this is not the time. This is not the time for it, right? Because there's a lot of instability going on here, and it is very easy for them to fall, and a fall could be tragic. So going back to your question, Fred, you might not see something as severe as a true hip coming out, but with the loosening of the ligaments of the pelvis, there can be a significant fall here.
What about the spine? Like
spine?
you're already overcompensating and leaning back, but I mean, I guess it's cartilage, like the vertebrae and all that kind of stuff. So I was just wondering if anything else would possibly go out of whack, like if you were about to have a slip disc, do your odds go up?
Well, usually that might happen as a result of a fall, but usually if she's careful, so to speak, and all of that, then typically it wouldn't happen. Yeah. Okay. We'll talk more about the waddling gait on Monday. Well, I'll just mention it now. Basically, the waddling gait is due to the fetus moving into the lower pelvic cavity and positioning for childbirth. So that's what caused it. Between that and the relaxed pelvic girdle, that is what you will see as a waddling gait. Okay, diastasis recti. separation of the rectus muscles of the abdominal wall. So it does happen during pregnancy. In the postpartum period, with exercise, those muscles can be tightened back, but the thin membrane that connects the left side of the rectus to rectus muscles to the right side, the membrane will not come back, but you can have the increase, the tone can be regained. But it's important to know that these muscles do separate during pregnancy. And so remember, your abdominal muscles, your abdominal wall is what is supporting your back. So with the shift in the center of gravity, the lordosis, it's important to think about this. These muscles are stretched, and so we don't have some of the support that we would normally have for the back. Okay, so, and in general, it's important for us all to remember that this is, especially for a profession like nursing, we're going to be doing a lot of standing, a lot of walking. It's your abdominal muscles that are really going to support your back. So these muscles can be strengthened and retoned with exercise. Usually exercise is enough to do it. Usually it doesn't require surgery. Whole lot of exercise, a whole lot of sit-ups, but it can be done, right? All right. So I forgot I included this. So there are different variations of diastasis recti. You might see some separation, more separation higher up, lower down, but it's basically the abdominal muscles that I want you to just remember. Okay. I gave you this slide about round ligament spasm, which basically explains anything that I was going to say about it. We typically feel it more, it's usually felt more on the right side because as pregnancy advances, the way the uterus shifts, it shifts a little bit more to the right. And so that ligament tightens more. And so there's not a lot that can be done for round ligament spasm more than moist, warm, like a moist, warm compress. Some gentle stretching can sometimes help, but that's basically what that is. Okay, so the skin, again, the largest organ of the body. We've talked a lot about hydration, temperature regulation, perfusion, all of that sort of thing for the skin. There can be hyperpigmentation, dark patches. Oh, let me write this in. So a hyperpigmentation to the face in the shape, basically in the shape of a butterfly, usually across the forehead, across the bridge of the nose to the cheeks, that darkening, that is, I think I misspelled it actually. Let me just make sure. The chloasma, no, I didn't. Chloasma melasma, so I put that in the chat box for you. Commonly called the mask of pregnancy. You might also see the lines on the abdomen. So I don't know, you can barely see on this slide. You can see it more here. This the line on the abdomen, you can barely see it here. I think you can see it more on this one. Okay. And of course, the striae gravidarum, which we commonly call stretch marks. So this is the impact of the connective tissue. That is your striae gravidarum. So striae impact different people differently. Some people have stretch marks, some people don't. Some people will tell you, use this product or that product or whatever. there's a wide variation. I'm not going to spend a lot of time on that. There's a wide variation about what can be done or what might not be done. For some people, stretch marks will fade, but for most, stretch marks do not fade after the pregnancy. Okay. So hair and nails, the hormones, one of the things that a lot of people like about the hormones is the hormones will promote growth of hair and nails. So not that everything falls out when after the baby is born, but the rate of growth will be a bit slower.
Professor, is it true that like postpartum, that sudden drop in the estrogen levels can cause hair to shed and fall out a lot?
So not so much that it will fall out and shed, but it the rate of growth will slow. Okay. So the vasculature, cutaneous vascular changes, you might see more, the vasculature becomes more visible, easily to see. You can easily see the vasculature a lot more. We spoke about the changes like to the breast tissue, how easily you can see the vasculature. Okay. All right, endocrine. Basically, everything is here. The BMR increases 20 to 25%. Body's got a lot of work to do. Thyroid might become slightly enlarged. You might need a little bit more iodine in the diet. Increased calcium and vitamin D requirements, particularly this time of year and during a pandemic when we're all inside, that be mindful of that vitamin D. Pancreas, placental hormones, glucose metabolism. I will talk more about that when we get to complications and diabetes. That's a whole conversation in and of itself. So I'm not going to spend time on that right now. So metabolism, weight gain, we've talked about. The only thing I want to mention, I think two things I might want to mention about water metabolism is that there tends to be a bit more water retention during pregnancy, and an increase, we see an increased incidence of carpal tunnel syndrome, particularly in women who are doing a lot of typing and so on. At night, because sodium and fluid tend to be retained during the day, the body just tends to retain them more during the day. They are excreted more when the body is recumbent. So you might also have more urine output later in the evening and at night. Carpal tunnel, I talked about carbohydrate metabolism. We'll talk more about that with diabetes, but basically we've talked about what you need to know already. The BMR, increased metabolic rate, all the work that the body is doing. Edema, we already mentioned the the changes in peripheral vascular resistance. So that's about all.
Sorry, I missed what you were referring to when you were talking about the increased urination later in the day or at night.
Nocturia. So water and sodium are more retained during the day and excreted when the body is more recumbent, reclining. So the volume, frequency of urination may increase in the evening and night hours. Excuse me, sorry. Trying to mute myself, couldn't get there fast enough. Question? Oh, you were saying bless you. Thank you. Sorry, didn't hear you. All right. The immune system. So the immune system basically is a little bit suppressed during pregnancy to allow for this quote unquote foreign body to grow within. So you have to think about that in terms of where we are in the middle of a pandemic at the beginning of cold and flu season. So pregnant women are more vulnerable to infection because their resistance is somewhat diminished.
What if
during-
they're already immunocompromised?
What do you mean already immunocompromised? What did you say? What if they are? Is that
Like
what you said?
already, like they enter pregnancy and they already have
Well,
it.
then, and they're even more immunocompromised then. So again, it's an important part of your teaching. It's not like there's anything you can do to change that, right? But what you can do is educate your patient on what they need to do, situations to avoid to diminish the possibilities of infection. So we are seeing, initially when the pandemic started, we weren't seeing COVID in the maternity population. It was mainly in the med-surg areas, but now we see it everywhere. Okay, so we have pregnant women who are stable with COVID. We sometimes have pregnant women who are in the ICUs, intubated, pregnant because of COVID. Okay, so it's again an important part of our teaching. White blood cell function lessens a little bit for the same reason, because of the pregnancy and allowing this growth to occur. Now, for some moms who have autoimmune conditions like rheumatoid arthritis, they may have a decrease in symptoms because remember, it's an autoimmune condition, but if the immune system is suppressed, they're not going to have as many symptoms. So pregnancy can actually be rather pleasant for them, but their symptoms will come back in the postpartum, shortly after the postpartum period.
Question. Is WBC function reduced due to hemodilation at all?
No, mainly due to the body allowing this situation to happen, right? The body is not reacting to the pregnancy. Okay, eyes. So the cornea thickens during pregnancy, a little bit of edema as well. So your contact lens wearing patients may have more discomfort. They may have to wear their glasses during pregnancy. Not at all unusual. Ears. Okay,
Professor,
so
I missed the beginning what you said. I missed we have to use the glasses. Why is that? I
the
missed.
cornea thickens. The cornea thickens. There may be some edema. So contact lenses may become uncomfortable.
Thank you.
You're welcome. So question is, are there mucous membranes in the ears? Yes or no?
Can you repeat, please?
I don't remember the name of the glands that produce.
Are there
cerumen.
mucous membranes in the ears? Yes or no?
No?
So you don't have to remember the name, but I'm just yes or no.
Is cerumen considered mucus?
So
Right, mucus?
mucous membranes in the ears, yes or no?
No.
Tympanic membrane is not a mucous membrane, and the cerumen, no?
So there are mucous membranes in the ears, yes. So the same, remember what we talked about the nasal pharynx? How the increase in vascularity due to estrogen can make the nose stuffy. The same thing is going to happen with the ears. So how might that manifest?
Muffled hearing, ear pressure.
Muffled hearing, absolutely.
Where exactly are these membranes located?
So not in the pinna, but further in the ear canal.
So more near the
Yes.
bones, or in the ear canal going down to the throat, or
Going further in the ear canal going towards the throat. Yeah.
okay,
So
so you
they
could
can
have
have,
backup
part of the
pressure
ear
there,
canal.
yeah?
In
I'm
the
sorry?
You
eustachian
would have
tube?
backup and pressure in there.
No, but what you're going to have is, so think about, for those of you, I don't know if this has ever happened to you, it's happened to me. If you go swimming, you go to the beach, the sea, the pool, wherever, pool, whatever, and you get a lot of water in your ears and your hearing is like a little bit muffled, that is the impact. That is the impact. Okay. So for my neighbor who keeps telling me that her husband keeps mumbling, I'm like, no, he's not mumbling. It's your hearing. You're pregnant and your ears, this is what has happened. So she keeps saying that he's mumbling. All of a sudden he's not speaking clearly. And I'm like, no, it's not him. It's you. So it does not increase the risk of ear infection, but those mucous membranes are going to be vasocongested. So she might have a little bit of a mild, almost like a mild hearing loss. Okay, so things may be a little bit muffled. It will diminish with when the baby is delivered and the hormones reduce. Okay, so again, caused by estrogen. Remember also, what other function do the ears serve? It's hearing and
Balance.
Equilibrium.
and we've just talked about the pelvic girdle, shifts in the shift in the center of gravity, lordosis, all of that. So all of this is important. Another reason for her to make sure that she's wearing supportive shoes. It drives me crazy during the summer when I see pregnant women in flip-flops, because I'm just like, no support for their feet, no support, never mind their backs, just no support at all. Just risky. Okay, enough about eyes and ears. All right. Changes of pregnancy. I gave you this as a large slide as a handout. I think we pretty much went through everything, but I did not. We talked about nosebleeds. But I forgot to give you this word. So epistaxis, we're talking about nosebleeds. Dialysis, we talked about most of this we have covered. So the lumbosacral curve, that's the lordosis we talked about. Waddling gait, we talked about. Increase in vascular volume. All right. So most of this, we pretty much talked about what you need to know here. Okay. Confirmation of pregnancy. This was on your podcast. The presumptive indicators are those subjective, objective, or diagnostic. Presumptive. Remember, presumptive are the indicators which she tells you she is experiencing. So those are subjective. The probable indicators are objective. Those are things that you as the practitioner can assess. But remember that diagnostic, there are only 3 positive diagnostic indicators. What you see, so you see the fetus on ultrasound, you hear a fetal heart rate, and you feel activity from the fetus. Only those 3. Now which slide is this? Okay, these were just telling you the other things, the some of the signs and symptoms, the presumptive and probable signs and symptoms can be attributed to other causes, okay? But positive indicators are positive, are diagnostic because they can only be attributed to pregnancy. Presumptive and probable can be attributed to other conditions. And so that's what this slide is. Or basically these slides, these next two slides, that's what those are. All right, antepartum assessment, we have already talked about all of this. Planning for pregnancy in advance, when she comes in for that initial visit, what needs to be done, what we're doing subsequent visits. Cultural considerations we'll talk about a little bit more with psychosocial. Common discomforts. So all of these, some of these we talked about yesterday, like the heartburn we talked about yesterday. Backache. So what are we telling her for backache? Low, don't wear those 4-inch pumps for one thing. So good supportive shoes. Putting her feet up when she can, resting when she can, and exercise is always helpful, swimming, yoga.
Professor,
I'm sorry?
about the backache, can be helpful using this belt, elastic belt to hold the
So
belly.
the supportive belts will sometimes, for some moms it will help. It depends on how supportive they are. Sometimes once later in pregnancy, because of the weight, the belts don't always give as much support because of the weight of the pregnancy, but they can be helpful. Round ligament pain, we already spoke about moist, warmth to the area. Urinary frequency, mainly what you're going to do is education. Make sure that she understands how to distinguish between the norm, what's expected in pregnancy and what is a urinary tract infection. Because if she has a urinary tract infection, that needs to be addressed immediately. Varicosities, primarily due to the decrease in peripheral vascular resistance. Maintain hydration, put her feet up. What else can we do for
Compression socks.
varicosities?
Compression and exercise is what.
Compression socks.
Compression stockings. What about varicosities that are basically hemorrhoids?
High fiber, high fluid, no straining.
Fiber, fluid, no straining. Sitz baths. She might also need to use witch hazel pads for the to diminish some of the swelling to the hemorrhoids. Constipation, do all that you can as far as nutrition teaching. And remember, always when you're doing teaching around constipation, the importance of exercise. So it's fluid, it's fiber, and it's exercise, all three, always. Okay, leg cramps. What might, other than your typical physiologic causes, what might leg cramps be attributed to? Something that we have talked about.
Low calcium.
So calcium. So back to your nutrition teaching. So what's her calcium phosphorus ratio and so on. So you got to go back to your nutrition. Okay. All right. Okay.
Yes, I have one, Professor. So
What's your
you're talking about diastasis recti, and you said that the abdominal muscles separate, and you never get the part that unites them. The part that unites it back, is that the linea alba that you're talking about?
No. So the linea alba is on the skin.
Okay.
This is on the skin. It's a darkened line on the skin. So it starts out very light. Before pregnancy, it's very light, and it darkens with pregnancy due to the hormones. That's on the skin. The diastasis recti is the actual, going the wrong way, abdominal muscles, separation of the muscles in the abdominal wall. And what holds them together, what is here, it's a very thin membrane. It's a very, very thin membrane.
Thank you.
You're welcome.
Professor, can you please repeat the nursing interventions for nausea, hemorrhoids, and leg cramps?
So leg cramps, we said that you also need to look at the diet to see what the calcium to phosphorus ratio is. Heartburn, we talked about yesterday. When we did, I don't remember whatever her name was, whichever patient that was that we talked about, small meals, avoiding fried foods, fatty foods, spicy foods, and so on. Hemorrhoids, avoid straining, diet teaching again, and she might need witch hazel compresses, pads, like Tux pads. So it's basically hemorrhoids are hemorrhoids, right? It's the same thing you talked about last semester in fundamentals. It's really the same thing.
Professor, for the hemorrhoids and constipation, would we potentially give them a stool softener?
So no, you're going to remember we always start non-pharmacologic, right? So you're going to
Right. No,
with the diet. You really try not to do a stool softener.
okay.
There are the suppositorian, like just to stimulate the last part of the anus, if just
So
in case.
really do not try to do any of that. It's diet and exercise. That's really where you're working, what you're working with, right? You try not to do any of that because it can have, any of those things can cause additional problems. Stool softeners as well as stimulant, any type of stimulant can cause additional problems.
So
So
the
you really try not to.
phylum husk caplets, would that be considered a diet?
I'm sorry, what are you, I didn't hear the first word.
I don't know how to pronounce it. I'll put it in the chat.
Okay. So the thing is that, yeah, we try to avoid all of that because those will, those have to be carefully managed because they can be used to treat constipation, but if she's not well hydrated, and we have specific hydration needs here. So if she's not well hydrated, if she's not exercising, there's always the possibility that that can make the constipation a little worse. All right, so we need to talk about psychosocial. Let's see which one this is. Okay. I'm going to switch gears to psychosocial. Okay. Now, there are probably about maybe more than 4, maybe 3, 6, 9. So probably 9 slides that I'm going to kind of skip over and just have you read. But they're not the main ones I'm going to talk about. All right. So those you can read, but the main ones I will talk about. Okay. So psychosocial responses, psychosocial changes. A lot of this will depend on some of the things that we've talked about already. What is her support system? Where is she emotionally? Where is she developmentally? And so on. But there are some things that we see regardless of where she is in terms of those details. So in the first trimester, there tends to be some uncertainty, particularly if this is an unplanned pregnancy, particularly if it's an unwanted pregnancy. So I mentioned that last week. We have to always think about, is this planned? Is this unplanned? Is this wanted? Is this an unwanted, essentially an unwanted pregnancy? So, the certainty, the manifestation of that are going to depend on how she's feeling about this pregnancy. Even if this is a planned, wanted pregnancy, there should be an expectation of ambivalence. Most women will have ambivalence. So some simultaneous conflicting emotions, so that that feeling of, I wanted to become pregnant, but now that I'm pregnant, I'm not sure that I'm ready to be pregnant. So that ambivalence, very common, to be expected, even if the pregnancy is planned, okay? So at this point in the first trimester, the self is the primary focus. Remember that physiologically, there are a lot of changes happening due to the hormones. So you may have also some emotional lability, some shifting in emotions because of the hormones. But first trimester, you expect some ambivalence. Second trimester, the physical evidence of the pregnancy, she's starting to show the pregnancy more. It's becoming more visible, more obvious. The fetus will, the presence of the fetus, the activity of the fetus, going to a prenatal visit and hearing the fetal heart rate, all of that makes it, the pregnancy, more real. And the fetus starts to now become the primary focus. So second trimester, we see a shift, and she becomes more concerned about protecting, taking care of this fetus. The fetus becomes more of the focus. There can also be some body image concerns, again, changes, the physiologic changes. Some of those changes are welcome. Some of those changes may not be welcome. So it's all, everyone is going to respond to that differently. So that has to be taken into consideration as well. Third trimester. So she's now, there is a vulnerability, there's an emotional vulnerability, there's also a physical vulnerability due to the physiologic changes and what she is physically able to do and not do. So there may be more emotional dependency. There will be more an increase in fatigue just due to the physical work of maintaining this pregnancy. Carrying this fetus is tiring, takes a lot of energy. All of the physical changes can be tiring, so increasing fatigue. There may be also irritability. So her body is beginning to prepare for childbirth, and she will also begin to mentally and emotionally begin to prepare for childbirth. So nesting, I want to talk a minute about nesting. So nesting in preparation of birth. There's a cultural component here that I think is very important to acknowledge. So for some cultures, it is fine to gather everything needed for this baby, to have it in the home, but not to prepare it, not to open it. Because in some cultures, setting up the crib, you know, putting everything away, putting clothes away, buying everything and putting everything away, so that the only thing that you're waiting for is the actual baby. For some cultures, that is considered taboo and can be perceived as bringing bad luck. So the question is always to ask Do they have the supplies that they need? Whether or not everything is set up, again, just remember there may be a cultural component to that. But in the third trimester, there is a natural urge to do to engage in nesting activities. Okay. All right. Changes in sexuality. Some of this I mentioned earlier. Sexual interest and sexual activity may increase, may decrease, may remain unchanged. You have the physiologic impacts, and then you have cultural impact. So depending on where she is in the pregnancy, how is she feeling physically, what's going on with her physically, and then of course her culture may impact, may make changes in that. So first trimester, the physical changes, the nausea, the vomiting, the frequent urination, all of that may interfere with erotic feelings, and so sexual interest and activity may diminish. Second trimester, I mentioned the pelvic basal congestion increases. So you might see some of that in the first trimester, but certainly in the second trimester, when the fetus is in the abdominal cavity, there's less pressure on the bladder. Most moms are physically feeling okay. There may be more interest in sexual activity. Third trimester, we have to be aware of supine hypotension, which we talked about already, fatigue from the work of the pregnancy, urinary frequency, shortness of breath, gastric discomforts. All of those may interfere with sexual interest, sexual activity. Sexual response varies widely among men and also has a cultural component. So for some cultures, sexual activity is fine during pregnancy. For some cultures, it's considered taboo. So we have to be aware of that and also prepared to answer questions and address any concerns about that, because we will be asked, patients will ask whether or not it's okay to engage in sexual activity or not. Okay. Okay. So maternal role transition, again, transition is experienced throughout the pregnancy. There are steps that she needs to go through, and then the maternal tasks of pregnancy. Okay. So this, I'm going to give you a couple of slides that I want you to star and then, excuse me, to go back and read. So this is one that I want you to read. I'm not going to cover this, but I expect you to read it. This one, this one, this one. Oh, just three. Okay. I thought it was more. 1, 2, 3. Those three. Okay. So I want to make sure that I have time to cover the other stuff. Okay. Paternal adaptation. So there are variations in how a father may adapt to a pregnancy. So now, as I'm talking to you, I'm honestly realizing that I have paternal adaptation here, and I will speak to this slide, but I want you to keep in mind that you may have a mother that is single by choice, or you may have a same-sex couple that you're dealing with, right? And you're not dealing with, you're working with, right? That you're caring for. So the adaptation may be a bit different, all right? Okay, so readiness for the partner is going to depend on the relationship stability. If the relationship was already on and off and on and off, pregnancy is not going to make it any better, or might make it better, might make it worse. It can just depend, right? Financial security, whether or not there's a desire for parenthood, all of that is going to impact on readiness. Sometimes for the partner, the reality of the pregnancy is different because they're not experiencing physiologic changes. So that has to be taken into account when we're thinking about adaptation. The main thing that I want you to remember that we tend to see with partners who are involved with the pregnancy, particularly if they reside in the same home, is KUVAD. So these are pregnancy, this is where I am here, pregnancy related symptoms and behaviors that we see in expectant partners. So typically what you see is she gains 10 pounds, he gains 10 pounds. She has heartburn, he has heartburn. She's tired and needs to take a nap. He's tired and needs to take a nap. That is KUVAD, okay? So pregnancy related, and again, we're talking about normal signs and symptoms of pregnancy related behaviors, symptoms in expectant fathers. And just a reminder here about parenting information, we always, if there's a partner involved, when we're doing our teaching, we always want to include the partner in the teaching, okay? Okay, grandparents. Age is a major determining factor in the emotional response of grandparents. So very often we will have, we might have a pregnant patient who has expectations for her mother or her father, what they are going to do. But meanwhile, the grandparents have their own expectations. So I can tell you many times I've worked with families that the patient thinks that her parents are going to babysit every weekend, and her parents are like, oh no, that's your baby. I have plans. That's your baby, handle it. I have plans for the weekend. So there can be sometimes those perceptions of who's going to do what can vary and can make for conflict within the family. The number and spacing of grandchildren can impact on how this particular pregnancy is received. The first grandchild is always more exciting. The first anything is always more exciting, right? So it's not that the other grandchildren are not loved, but if they're not first, the reception might be a little bit different. Siblings. Toddlers will have very strong feelings. If you're working with a mom who has a toddler, you have to remind her that this is also a safety issue. Toddlers, very often, particularly young toddlers, do not have the verbal ability to express their frustration. And so it will manifest. They will throw things, they will kick, they will fight, they will demonstrate their frustration, all right? School-age children are more interested in being involved in the whole process. If she has adolescent children, they tend to be, it depends on their developmental level, but it's not unusual for adolescents to be just a little bit mortified. So I have taken care of many families that they have an adolescent and the adolescent is just like, I can't believe my mother is still doing that, right? So they tend to think, you know, we tend to think of our parents in certain ways that, you know, I guess once we were born, that was the end of their sexual lives. So adolescents tend not to respond very well to that. Okay. So again, your psychosocial adaptations will depend on many things. The developmental level, does she have children? What is her support system? Does she have a partner? Are there mental health issues? Is there an issue with IPV? And what are the psychosocial concerns? All right.
I have a quick question. The slides that you said know really well is the paternal adaptation, the maternal role transition, and the adaptation of grandparents?
No, I said the three that have this one, and this one. They are the two with the steps of maternal role taking, and this one. Those are the three that you should read. The ones that I'm covering, but the other three you should read. Right? Okay. Cultural issues. So we need to be mindful that many religions, many cultures will have a preference for female providers. Sorry, guys, but that's honestly the reality of it. There may be a preference for the place or the setting for childbirth. Culture tends to play a role in that. Also, who is present at the birth. There may be ceremonies and so on that need to accompany this, the pregnancy and the delivery and childbirth process. And culture can play a role in nutrition. Pain and pain management, we will talk about week after next, but remember the impact of culture on pain. So I think you've spoke about this in fundamentals. There are some cultures that are very stoic with pain. There are some cultures that are very verbal when there is pain, okay? Pain is what the patient says it is, but just be mindful of the fact that if a patient tells you they have no pain, that doesn't mean that they're not in pain, all right? Okay. And then there can be cultural norms and traditions around postpartum and around hygiene. So it's always important for us to remember that differences in culture can result in conflict. And so those differences may be between us and our patients. They may be between the patient and family, sometimes in-laws, sometimes husband and wife, right? So there can be differences that result in conflict. There are cultural differences between and within cultures. So for instance, we cannot say that everyone that is of a certain culture does the same things, because there would be certain pockets within that full culture, all right? And we have to be mindful of that. Culture plays a role in our health beliefs, our beliefs of fate, like what I mentioned before about nesting and it being taboo. So I've had patients that have said to me, oh, I shouldn't have done this, that, because then I brought this on myself. This was my fate because I did something. So methods of preventing illness, of restoring health, all of those have cultural implications. Modesty, there are some patients who will not disrobe, who will still cover up. So we always have to be mindful of those sorts of things, all right? So my statement to you is to always practice culturally aware nursing, and you might have to engage in some cultural negotiation, okay? And I think this basically says the same, all right? So just being mindful of our own culture, our beliefs, and how that can impact in how we're working with our patients. So illness will be viewed very differently. Pregnancy is not a condition of illness. It is a healthy condition, right? Unless there are complications. And so you may have patients who never come in for prenatal care because for them, they don't see the reason that they need to do that, right? And we have to, when we work with those patients, we can't work with them from a standpoint of judgment, okay? So again, just individualizing our care, supporting the patient's beliefs and their culture and traditions. And all of these things factor into, this is very similar to the other slide that we had. All of these things factor into psychosocial adaptation to pregnancy and to health and to illness, okay? All right, so I know we covered a lot today. Are there any questions? This last little bit we covered fairly quickly. It's not a lot, but you've done a lot of the psychosocial stuff already in psych, but just a few points that I wanted to point out. So any questions for this or from the physiologic changes?
Professor, so
Yes.
cultural influences on childbearing for modesty, what is that exactly?
So modesty, So I'm talking here about, you know how we'll have a patient come in and we'll say, put on the gown. Some patients are fine with having the gown open, but you have some patients who will still are very modest and who will still want to be covered up as much as possible. So we just have to be respectful of that, particularly if there is a male provider. She may be uncomfortable with that. So just being mindful of that.
Okay, thank you. Thank you.
You're welcome. All right, so other questions, anything?
Just a comment on how you posted the PowerPoints last night, or your slides. That was much better for us to be able to like grab them and do our notes off of, like, because you did 2 per slide. You also posted one in black and white and one in color, but I don't think you necessarily need to go through that effort on your end, because if people need to print in black and white, they can just choose that just to save yourself some time.
Oh, it didn't, yeah, actually I had done it in black and white initially, and then I went back and said, oh, they might want the color. Okay, thank you.
Yeah.
Thank you.
So, the short case study will be available after class. I did adjust the, that little matching quiz that it won't take you more than maybe 10 minutes to do. I think I increased it, the number of attempts. Tomorrow I will post very detailed instructions about clinical on Thursday, but a couple of things I want to remind you. So clinical will be on Thursday. Make sure you check your emails. Your clinical instructors will send you an email letting you know, giving you the link to the Zoom pre-conference and post-conference and what time they expect you there. Make sure that read the document that I posted about clinical. So make sure you're in your uniform and everything that is listed there is done, right? So that we don't have any issues with clinical. You will have a couple of assignments this week. So there will be 3 scenarios on the Davis platform for you to do, and then a case study, okay? So remember that you will need to upload everything to Blackboard. In the same tab that the clinical document is, there will be a folder for Thursday. So everything, you will just go into that folder and everything will be there. But please make sure, as I said last week, that your documents are labeled with your name. Do not post anything that doesn't have your name on it, okay? So it needs to have your name on it. I will post all of this anyway tomorrow so that you'll have it. The case study will be there so you can download it from Blackboard. And I think that's it. Your quizzes will begin on Friday, the Davis quizzes. Oh, so those of you who, I'm going to ask those of you who have a rented or you don't have an access code. If you don't have an access code for Davis, please just wait a few minutes after class and I'll talk to you about what to do. But I think that's it. So if there are any other questions, do post them, please, in the discussion board. So the matching, it's for class. The case study is for class. They're not for clinical. What is for clinical are the Davis scenarios and the case study. Okay.
Okay.
Okay, so I think that's it. So I'll talk to those of you about access codes in a minute, and then otherwise, I will see some of you on Thursday. The rest of you I will see on Monday.
Thank you.
Thank you,
You're welcome.
Professor.
Have a good day at clinical.
Thank you, Professor. Bye.
You're welcome. You're welcome. See you later. Okay, so is it so tell me what the status is with your access codes. I know that some of you have rented, right?
Yes, I rented the book and I was able to insert the access code, but it just says my friend's email, the BMCC email, but I could change it to say my name, but I can't change the email for the Davis website.
Change the email. So then,
Like, will
okay,
it still say it's my name? Because she never used it. She actually had my clinical professor, and they didn't use Davis. So that's why she was like, use it.
okay, so you know who it is.
Yes, the clinical professor, yeah. It's the same one she had for her lecture. Forgot her name.
Was it this semester?
Yeah, yes. For the evening professor.
Oh, okay, so Professor Press.
Yes, Professor Press.
Which group are you in? I don't remember.
I'm in Professor Press's clinical group.
We might be able to, all right, so I might be able to work that. Okay, so I'll come back. So what about the rest of you?
I'm waiting for my code to come in the mail. Because you get because you get the book in the mail and that comes with the code.
Oh, so you haven't gotten it as yet. So try to call them today to see what's happening.
Will do.
Okay, to see what the status is. What about the rest of you?
So I mean, if I haven't purchased it yet, I was going to rent it if it was going to be cheaper, but if there's no way for me to get access by renting it, then I guess
Yeah. See, that's the problem. I mean, Jasmine, I think you kind of lucked out that you ended up with some renting from someone who, but what are the chances? You might not be as lucky, Victoria. So that's the thing. The access code, remember, it will give you access to the weekly quizzes and to the scenarios that will be part of the clinical assignment. So yes, renting is going to be cheaper. That's just the reality. But then you won't be able to do all of the other things. So that's the issue.
So I guess I might end up running into the same issue though that Andres has if I order it and I'm waiting for it to be shipped with the access code.
Right. Yeah, because it will take a little bit of time.
I'll just order it and see. Or maybe
order it. Oh, so both of you, you know what, you and Andres, I'm going to have both of you do the same thing. See if you can go on to the site, if it will allow you access, because you might, and Jasmine, you as well, you might be able to, when I post the instructions for tomorrow, you might actually be able to access.
I think you're right because it gives us
scenarios
about 20 days until
like a temporary
license expires. Exactly. So we might be able to.
Yeah, you might be able to at least access what you need for Thursday.
Okay.
Great. Hopefully you'll get it in time to be able to do some of the quizzes to prepare for the exam, but you should be able to do this for Thursday. Okay.
All right. Thank you.
You're welcome. And so what about the rest? Sung, Karen, and Nurizanat, what about you guys? Are you there?
Yeah.
Okay.
Confusion about purchasing it. I think they posted a link in the WhatsApp, but it says like it's a wrong code.
It should be, if you go back to Professor Britannico's Blackboard, because she posted the book list. I can't remember, I think in course materials or something like that.
Okay.
There's a folder there, and it'll be faster for you to look in her Blackboard than for me to find it. There's a flyer there for how to order it.
Oh, okay. I'll check that out.
Okay. Okay.
Thank you.
You're welcome. What about Karen and Nurzanat, are you there? I see you, but I can't.
They're
Okay.
probably busy and they didn't know I ended.
Yeah, maybe you
Yeah,
didn't
maybe.
log out.
Okay.
All
All
right.
right, so this is what we'll do. We'll try that. Some of you are going to check Professor Britannico's Blackboard. I'll post the instructions tomorrow, and you should be able to at least access enough to get in for Thursday, okay? So, yeah, so you shouldn't have a problem. If you do, then at least let me know, send me an email or whatever, and then we'll figure something out, okay?
So the quizzes are all due on Friday?
The quizzes will open on Friday and they will be open until the night before the exam. So our
Oh,
exam is
awesome.
on Tuesday and they will close on Monday night.
So we'll be able to have multiple tries on the Davis website with the quiz or no, just one time?
Can't remember. I think you have more than one. I
Oh,
think
good.
you can, yeah, I think you can go back and take them.
Oh,
Yeah.
awesome.
Okay.
All right.
All
Thank
right.
you, Professor.
You're welcome. So if
Thank
anything,
you.
you'll send me an email, okay?
Okay.
All right.
Bye.
Have a good day.
You too. Thanks.
Bye-bye.